I'm not going to give it to you just now, because I would like to give you first some insights and some questions about the study. It's a study that tries to look at the relationship between preeclampsia and cerebral palsy. So preeclampsia is a disease of the mother with hypertension, and this hypertension can alter fetal growth. So you have growth restriction in preeclampsia, and you also have its complication on the mother's point of view, and she can have a severe condition. So we ask ourselves, does the severe condition of preeclampsia, could it produce cerebral palsy, which is a motor abnormal development? So on one hand, we have preeclampsia, the status of the mother. We have also preterm birth, because when the mother is preeclamptic, you have to get the fetus out of there, on part to save the fetus, but also to save the mother, because it's only by interrupting pregnancy that you can stop preeclampsia. And so the authors are trying to explore the relationship between preeclampsia and cerebral palsy. And so the first thing I would like you to try to see is looking at the introduction, because the question is always in the introduction, okay? Looking at this introduction, what would you say would be the aim of their study? So, who goes for it? What can you see as an aim of their study? What's the goal? You're somewhere by there?
Yes.
Yeah.
Timing.
Yeah, the timing of onset of preeclampsia. Does it influence association between preeclampsia and cerebral palsy? So their first question is, because preeclampsia can be revealed in the mother at different stages of pregnancy. So their first question is, looking at when preeclampsia occurs, does it alter the association between preeclampsia and cerebral palsy? That's their first question. Yeah? And the second one is here. So, whether in preterms or in full terms, is there a different effect of preeclampsia on cerebral palsy? Okay? So they have two questions, actually. They address two questions. So, just to say that classically, evidence-based medicine, you could say there are three steps. The first step is quality of data. And this is true whatever the type of study. We talked about meta-analysis. It's the same thing. Luigi passed some time to tell you that you have to look at the quality of data. And if the response at the quality of data is not very good, you should stop reading the paper, actually. And that's something very difficult. Generally, we skip to the results. And really, it is not reasonable to look at the results if the quality of the study is bad. But I agree it's difficult. Okay. And this is what we call internal validity, what Marina talked of this morning a bit. If the data is of good quality, then you should look at the length, the magnitude of effects. If we look at the relationship between breastfeeding and intelligence coefficient, Well, yes, there is a statistical association, but the magnitude of the effect is about 1 point of intelligence quotient. So there is an association, but the magnitude of the effect is not very important. And also, never forget to look at the clinical importance of what they're looking at. If we look at postnatal steroids, so in neonatology we use steroids before birth, and that the beneficial effect is really is really demonstrated. But we use it also after birth for other reasons. And there have been several randomized trials looking at the effect of postnatal steroids on pulmonary morbidity. And they all look at glucose dosage, you know. And so everyone knows that when you give steroids, you rise glucose dosage. So that was really an uninteresting outcome. Nevertheless, the 7 first trials look at that one, okay? And the 8th trial looked at outcome at 2 years and cerebral palsy. So we discovered at the 8th trial that postnatal steroids increase cerebral palsy. Well, it's a bit of pity. So you have to look at the magnitude of the effect and the importance in clinic of the outcome that has been chosen. If the data is good, if the magnitude is interesting and of clinical importance, then you have to ask yourself, should you extrapolate the results you are seeing? And this is really all around the selection that Marina talked about. As you saw this morning, selection, it can intervene at the inclusion in the study, and then it can intervene during the study. And so when you have selected a population to be included in your study, well, it will be difficult to extrapolate to another type of population. So this, you should keep this in mind, even if you have interesting results. So for this example, as we don't have much time, I will not look at quality of data. I suppose that the quality of the data is good. If you have time, I'm going to give you the paper. If you have time, when you go back home, just look at the origin of data. It could be discussed as a good quality or not, okay? But let's suppose that quality is good. And now, they describe their conceptual model of the problem. And so what I invite you to do, and maybe to refresh a bit before eating, I would say that you put yourself around a table and looking at this, try to make the DAG of their problem. Okay, so just put yourself around tables, maybe 1 or 2 groups, not more, and discuss about it. Try to draw the DAG around this chapter. Just try it. But you have to move. Don't be timid. Shy. Just as you can see the graph in the paper, okay? So, they have taken globally risk factors of preeclampsia, and effectively they have split it in early versus late, okay? So if you're early preeclampsia, you provoke preterm delivery because you have to save the baby and the mother. As late preeclampsia has in fact a direct effect on the brain. It doesn't pass by prematurity or whatsoever. And so if you have medically indicated preterm birth, you pass by preterm birth, which is linked to cerebral palsy. Okay? And the other important factor is infection, because infection can lead to spontaneous preterm labor and so prematurity, and it can have a direct effect on cerebral palsy. What you didn't know, because it's a bit specialized, is that intrauterine infection can also lead to medically indicated preterm delivery. Okay. So looking at that, don't forget that what we're looking after is what should I adjust on, and that's confounders. And should we adjust on gestational age? Well, no, we shouldn't, because as you see, two arrows get to preterm birth. So it's a collider. And the important thing to understand is that when there is a collider and that you don't adjust on it, it blocks the path. So intrauterine infection is blocked here, it's blocked here, and it remains the direct effect on cerebral palsy. But it's not linked to preeclampsia, so it's not a confounder. It's a difficult gymnastic, I'm okay with that, but you should always remember that what we're looking at is what is associated with preeclampsia and what is associated with cerebral palsy. And looking at that, the collider has blocked some paths. If you adjust on preterm birth, you will open a path between the two causes of preterm birth. That is, you will open a path between preeclampsia and infection. So if we adjust on early, late, or if we can't adjust, we could just stratify analysis on late and preterm, and we could adjust on intrauterine infection if we had adjusted on the collider, because we would have opened a path. So actually, the results they give, the first thing is timing of preeclampsia, which was their first question. And you see that there is a statistical association between preeclampsia before 37 weeks and cerebral palsy, before 20 weeks and cerebral palsy. So they see that early or late, there is an association. And they adjusted on 3 variables. So actually in the DAG misses 2 other variables, who are race and maternal age, which we could try to put in the DAG. So this is the other question of how you choose your confounders. Usually, as I said this morning, you choose the confounders to adjust on with one table which shows the outcome, yes, no, and the list of your variables. And so you see here there's race and maternal age. Why did they take those 2 variables? Because they are associated in the literature to cerebral palsy. So another way of having an idea of which variables you should be interested in is medical literature. And here you see that race is not statistically associated with cerebral palsy. It's at the limit of signification. You see, you have a p-value of 0.07. So you would say that this is not associated with this because it's non-significant. But actually, when you do a univariate analysis, as I said this morning, the associations you see are potentially false. And so what some authors recommend is to be much larger in the p-value, where you would say, there's maybe an association. So some take 0.20 or 0.30. just because a simple analysis without any confounders taken in account could be false. So that's why they took race and maternal age. All the other ones are associated, and that's why they adjusted on them. If we adjust for here, yeah. Well, if you adjust on the collider, as we said this morning, you will open new paths. And if you block the other paths by adjusting on them, it isn't a problem. So even if you adjust on a collider, yes, if you adjust on all this and the collider, yeah, it could be okay. But don't forget parsimoniously choice of the variables, so it wouldn't be interesting. And the other question is, when you have a collider, did it open other paths that you don't see? But that we discussed this morning, you don't know anyway. Okay? Okay? This is just an example to show that we can find a collider by the DAGs. Yeah, Hobby is puzzled. It is complicated, I'm aware of that, yeah. You see that to block this, you have to adjust on the three paths. So this is why they adjusted on intrauterine infection. They didn't adjust on an intermediate variable. Well, not an intermediate, but the next step. They could have blocked these paths on adjusting on this, this, or this. But they decided to adjust on this, which blocks the three paths. Yeah. And if you look at the paper, they estimated intrauterine infection by urinary infection, which is a proxy. Okay. Okay. Just to say that they looked also at prematurity and cerebral palsy, which was one of their questions. Does it, in the preterm, is it associated? Excuse me. And so effectively, it's associated. Early preeclampsia is associated, adjusted on these confounders. And just late preeclampsia isn't. So that was one of their questions. So they respond in the preterm, do they find a relationship between early and late? And this is interesting also because as you didn't adjust on gestational age, you can only give results by strata of gestational age. You can't combine all the preterm and term infants. For the quality of data, if you read the paper, you'll see in the discussion, they were a bit suspicious about some of their outcomes and some of their expositions. And what they did is that they did an analysis with everyone and the analysis with those for which they were sure of the outcome. And they found about the same results. That's what we call a sensitivity analysis. It's just taking subsets of data and looking at, does my relationship persist, my association persist or not? You see that in meta-analysis, for instance, when Luigi said you take all the trials and you take just the low-risk bias trials. And if you find about the same result, it's rather reassuring. Yeah. Yeah. Okay.